get going. They're taking lots of short shuffling steps trying to get underneath the rest of the body again, and they just really can't recover, leading to a fall. So that's just the Parkinsonism. So those are the clinical features we're looking at on exam. The specific diagnosis can either be Parkinson's disease or a Parkinson's plus disorder. So all of these have these same core features, but a little bit different variety within them. So, Parkinson's disease is due to a buildup of alpha-synuclein, and then they have a progressive loss of the dopamine producing neurons within the brain, specifically in the substantia nigra, and then kind of other cells within the brain are also affected. Why this happens? So, it's usually multifactorial. So, there's aging process, our incidence of Parkinson's increases the older the brain is, the more we age, as well as your genetics. There's a handful of known genes which are very clearly linked with Parkinson's, but there's also just your overall genetic environments where some genes which affect your immune system, propensity to inflammation, mitochondrial function, or lysosomal function, interact with these environmental exposures over your lifetime, including certain viruses, certain toxic exposures, whether in the air, drinking water, kind of work environments, or kind of wherever you might be exposed to something. Kind of those whole interplay can lead to more inflammation within the brain and then decrease of these cells over time. It is slowly progressive, so this tends to take many years before we even notice the physical motor symptoms. You might have symptoms like constipation, loss of sense of smell, and acting out of dreams before we notice any of the tremor, stiffness, slowness that we need to make that clinical diagnosis. Usually Parkinson's is going to be asymmetric, so it'll tend to start on one side. Eventually, both sides become involved, and that's a little bit variable from person to person. Can look a bit different, again, based on that multifactorial causes. So not everyone's Parkinson's looks exactly the same. And Parkinson's disease, another supportive criteria here is that they have a good response to carbidopa, levodopa, or Sinemet. So replacing that dopamine seems to work quite well for their motor symptoms. So they have less tremor, less stiffness, their walking might improve fairly dramatically. Right now, we don't have any sort of cure or a disease modifying medication, though. Again, largely due to the fact that there's multiple things contributing to this, not one specific cause for everybody. And as the disease progresses, then we start seeing more motor fluctuations, right? Where the carbidopa, levodopa used to work quite well. So they're in this green state where they're not having any wearing off or any kind of symptoms of too high of dopamine. As it progresses, that window narrows. And so those same medications aren't working quite as well to produce the good on-time motor symptoms that we want. So they have a variety of different motor symptoms. So that can be when we take the pill, we aren't getting that on response quite as quickly as we wanted to, or that dose is starting to wear off a lot faster than it used to. So we're having to spread things a little closer together rather than farther apart, like we maybe did earlier in the disease. They can also have unpredictable on-off times, or all of a sudden in the middle of my medication dose, for some reason, my walking's just not doing great. My tremors coming back very dramatically. And then dyskinesias are those extra wiggle wormy movements. So if you've seen Michael J. Fox, he has a fair amount of dyskinesias. And those typically are going to be at the peak dose where we're having too high of an effect of the dopamine. So rather than too little movement, we now have too much movement from that dopamine. And then dystonia, so that's an abnormal pulling or posturing of muscles. We can see that usually more on the affected side. So again, the side where the Parkinson's started might be a hand kind of curling in, or the fingers aren't doing quite what they want them to, or the toes curling under. Some people will get a cervical dystonia, either pulling to the side or pulling more forward. Again, typically in Parkinson's, this is later in their disease course. And then freezing of gait, that's again when we're walking, all of a sudden we're getting stuck. Either one foot or both feet just won't move forward like we want them to, which can predispose us to falls if it's all of a sudden we're kind of stuck. And then Parkinson's plus disorders. So we'll go through a little bit of what these ones are. Not going to spend a huge, extensive amount of time on them. Again, reminding that we have similarities of we've got the stiffness, we've got the slowness in all of these diseases. Tremor tends to be a little bit more variable. We don't tend to see as much tremor with these disorders, but we see other symptoms, which is where we get that plus, right? So it's the Parkinsonism plus and progressive supranuclear palsy, we see very early falls. They have a lot more profound axial rigidity, so that core is very tight, and then that leads to early postural instability. So they're more prone to those kind of tipping over falls without a clear reason. They also have a lot more difficulty with eye movements because the areas in the brain that are degrading faster are the areas that control those eye movement abnormalities. So they have a lot of problems looking down as well as looking up, but mostly down. So they have more trouble with stairs, with getting their eyes to follow from one line to the next one. And that can lead to, again, a significant functional impairment for them. Cortical basal degeneration is similar to PSP as it's a tau, so it's a slightly different protein than the Parkinson's patients, but can look very similar with those basal ganglia changes. So cortical basal, meaning they have cortical findings, so they have atrophy usually in a parietal lobe on one side versus the other, as well as the basal being the basal ganglia. And so those are the deep structures that are interacting with those dopamine cells, which produce the Parkinsonism. So the cortical basal then has both cortex signs as well as basal ganglia signs. The
We have
main
a question,
cortex,
Dr. Sipma.
yes, go ahead.
Angela Rosamano is asking, with Parkinson's, my father never developed the tremor, although his father and brother did have the tremor. How rare is it to not get the tremor? In other words, was that unusual?
So about a third of our Parkinson's patients may not have tremor. So there's kind of two subtypes of we have a tremor predominant subtype of Parkinson's or a more akinetic rigid where we have more of the stiffness slowness part of Parkinson's. So they tend to be two-thirds have tremor, a third don't. So not uncommon, not unheard of. Again, more likelihood with these PD plus that we don't have a significant amount of tremor. But again, it's not required with the criteria to, you only really need two out of the four. So you don't need tremor to make a diagnosis, but can be helpful if it is present. So. All right. So yeah, so going back to cortical basal, it can look like Parkinson's in particular because it's more asymmetric with onset. So again, you have one side which is largely affected. But in addition to slowness, stiffness, potentially a little bit of tremor, you might also have apraxia, which is a trouble getting the hand or the leg to do the thing you want it to do. So they may develop an alien limb where no matter how much I tell my hand to go grab the thing, it's just not listening to me, won't do the thing, or you can't get my leg into my pants because it just is not cooperating, won't listen to that brain signal telling it to do what it should be doing. Graphesthesia is a sensory problem of their nerves are fine. You can tell that there's pain, but they don't have the processing of that sensory input. So they can't tell what is being placed in their hand and have some of that processing issue because of the cortical degeneration. Myoclonus is a quick jerking of an arm or a leg or a muscle group, which again is just a signal of we've got some degeneration going on in the brain. These patients tend to have more dystonia fairly early on, especially in that affected side. So again, I frequently see these patients with a hand really curled up, twisted up, where those fingers are digging into the palm or starting to develop contractures and more pain with them in particular. And then tau is also involved in ALS and frontotemporal dementia. So some of these patients might have a lot of muscle weakness or wasting, or more of the dementia symptoms with behavioral changes, potentially aphasia as well, which is more difficulty speaking and producing speech. So those can all be kind of within the spectrum of cortical basal degeneration. And multiple systems atrophy has, again, the Parkinsonism plus a lot of early autonomic dysfunction. So this primarily looks like orthostatic hypotension, where your blood pressures drop significantly with standing. But they also have a number of other things under autonomic control, right? Your severe constipation, they might have urinary incontinence, bowel incontinence. Again, your eye kind of dilation is under autonomic control. So you might have more visual trouble, temperature dysregulation, where they're feeling very hot, very cold, or sensitive to temperature fluctuations, unlike prior. Um, and then dementia with Lewy body is really kind of based on timing of cognitive symptoms and hallucinations. We can have Parkinson's dementia much later in the course of Parkinson's disease, where we've had motor symptoms for So many years, and then we're starting to get cognitive decline. Whereas dementia with Lewy body starts with more of the cognitive decline. We have hallucinations, delusions, or paranoia within that first year, either starting before the motor symptoms or within that initial year of onset of the tremor and stiffness and slowness. So mostly timing and multiple system atrophy and dementia with Lewy body have that similar alpha-synuclein protein, so they can look very similar to Parkinson's disease in those early stages. And with time, we can kind of further differentiate which one we're dealing with there. All right. And so again, just talking in general, most of these PD plus disorders are younger at onset. So typical for Parkinson's is kind of age 65 to 80s is where we're seeing most of our Parkinson's onset. You can have young onset PD, again, mostly because of genetic causes. But our PD plus disorders tend to be kind of more in our 50s, early 60s, and they're more rapidly progressive and variable. So these patients might have, again, progression to wheelchair within 3 to 5 years, whereas that's not going to be expected for Parkinson's for many years down the road. Um, Again, early falls, early morbidity, mortality. On an MRI for a Parkinson's patient, you're not going to see a whole lot of atrophy or shrinkage of the brain, but with these other PD plus disorders, you might see a little bit more. So, like cortical atrophy up in this top one looks like a cortical basal degeneration. MSA can have more of the pontine atrophy, so you have this kind of hot cross buns or hyper intense signal in the pons. The PSP has more midbrain degeneration, and so you see kind of thinning of another part of that brain stem that I didn't show on these slides here. And none of these have any cures or any disease-modifying medications in particular. We will still try levodopa on most of these patients, but oftentimes are limited by side effects. People with hallucinations are getting more hallucinations. The MSA patients with drops in blood pressure are getting more hypotensive, and so we can't walk because their blood pressures are so low. So it's kind of a trade-off of how bad are the movement symptoms versus their other symptoms. Do we need to try and focus on one of those other more worrisome, more bothersome, or dangerous symptoms of this disease rather than the movements in particular, at least with medication side of things? Because that's where, again, physical therapy, occupational therapy, speech therapy, we can still target those motor symptoms, but without the side effects like we have with our medications here. So other symptomatic therapies might be used too. So I might use muscle relaxants if there's a lot of spasticity or dystonia for a patient. Again, pressures for the medications for the blood pressures if those are running low, or meds to help with the cognitive symptoms might be useful depending on, again, what the patient is complaining of specifically. So kind of getting into more of the, again, physical therapy role here specifically. So there's the Lee Silverman therapies are courses that physical therapists and speech therapists can go through to get more familiarity with people with Parkinson's. So the big therapy through physical therapy is focused on how are we walking, being intentional with a lot of our movement. So are we taking big steps rather than taking those short shuffling steps we're going to naturally kind of find ourselves going into? Parkinson's patients don't swing their arms very well, right? And so, how do we swing our arms, be a little bit bigger with our movements, not those small, shuffly, kind of unsteady steps and movements like we're going to be prone to making with Parkinson's? So, it's a lot more of like thinking about how we're walking, moving safely at that. Uh, so there's a number of different kind of high evidence, useful recommendations in regards to physical therapy for Parkinson's specifically. Less so because the other disorders are more rare, so it's harder to study these interventions in our Parkinson's plus. But the same sort of concepts of if these patients are just kind of like Parkinson's but a bit worse, our focus is on aerobic exercise, resistance training, core stabilization, trying to help them prevent falls really with the balance training is the big thing. None of my medications, none of my pills will prevent a fall. But the physical therapy, the working on the balance and how we're making movement safely is better at that fall prevention. All right, so home safety evaluations too. Are we in a setup where, again, over the course of these next, 5 years, 10 years, 20 years, as this disease progresses, do we need something that's got fewer steps, that's got wider hallways, so we're not prone to freezing in them in particular, or bathroom handrails or other things to make this a little bit more safe as our balance becomes a bit worse, knowing that that's in our future here. Assistive devices also particularly helpful. On the right side here, we've got a demonstration of a U-step walker. So U-step, because of that wide U-shaped base, it's got wheels which will turn, so you have a good turn radius on it. The brakes will help it stay steady rather than the typical walker, which is going to keep rolling if you're on a hill or let go of it. This one, if you need to let go for any reason, it's going to stay stationary. It won't roll away from you. It is a bit heavier, which can be a little bit harder for transportation purposes, but it provides more stability to help the people from falling backwards or from just going over with another flimsy other model of a walker. Um, and then other big things too for Parkinson's is like we mentioned with the brain sending signals to the body just isn't working quite as well as it used to. So these patients respond fairly well to external cueing. So rather than just saying, okay, foot move, they need something outside of their body to help break that. So that can be visual. So these walkers come with like a laser, which you can point so you have something visual to try and step over. Other common places are narrow spots where they have trouble. So bathrooms or hallways or closets or pantries. Again, giving them a visual like checkerboard pattern or tape with lines on it. So that way they have something visual to try and step towards or step over can help with that kind of bypassing the brain circuitry. Auditory works as well. So this other cueing module on the walker comes with a metronome. So you can have a clicking, which will also, again, give them a 1, 2, 3 step sort of rhythm. Some patients will hum a tune or sing a tune or count out loud, and that'll help them kind of keep moving and break some of those physical restraints that their body's kind of imposing on them through this disease. Occupational therapy as well, typically very paired up with physical therapy, looking at home and or work recommendations, right? These patients are getting closer to retirement age, but may not be at that retirement age. So they're trying to work for as long as they still can. So do they have a lot of tremor where they can't write as well for their job? Do they need tremor specific pens, or can we adapt it to typing or some other mechanism of still letting them work, giving them that independence for as long as we possibly can? Um, Again, working on what tasks are you specifically having trouble with? Is it the tremor that's interfering with it? Do we have something that can combat the tremor? Do we have dystonia, kind of that pulling, which is giving us more problems? Do we need to do some range of motion exercises with the dystonia to get more of that flexibility from those, just from the therapies? Or do we need to combine that with something like Botox injections in a cortical basal patient to give them at least better function or less pain from that progressive debilitating dystonia? The other place I'll frequently use occupational therapy is for driving evaluations, because it is largely a mobility problem, but there's also a slowed processing speed with Parkinson's and more severe with dementia with Lewy bodies or PSP in particular. We can have, and the cortical basal where you have more cortical dysfunction. So it's not just the mobility, but also the reaction time. Can they multitask well? Visual spatial can also be very impaired in our Parkinsonian patients. And so are they just not judging the distances correctly anymore? And is that impacting their ability to drive safely? So, driving evaluations with an occupational therapist can be helpful in kind of assessing that. Patients are not great, or they don't necessarily want to give up that independence of driving. So, how do we kind of give them more objective data of like, you think you're reacting quickly, but this really shows that you're not. And so, kind of give them some guidance on some of those hard decisions there. And then talking a little bit more on speech and voice. So again, just like the other muscles are affected by the slowness, stiffness, the vocal muscles, the muscles involved in swallowing are also affected in Parkinson's. So they tend to have softer, more breathy, monotone voice. They might have more slurring where it's a little bit difficult to understand. Some patients have tremor, which affects either the jaw or sometimes the vocal muscles, less so that vocal muscle with Parkinson's compared to essential tremor, but is possible. And then alterations in timing. And swallowing can also be significantly affected. About 90% will experience some sort of difficulty with dysphagia, and aspiration pneumonia is actually our leading cause of death in many of these patients. So again, falls, high risk of morbidity, mortality, and those aspiration pneumonias are the big things we want to try to avoid with these patients. So, uh, A little bit with the speech therapy, similar to the LSVT big. LSVT loud is focused on how do we modulate our posture, how do we affect our breathing in order to project our voice a little bit better. How are we thinking about our consonants? And again, trying to optimize that communication for as long as we possibly can. Again, with that dysphagia, we might want to do some early evaluations, whether instrumented or barium swallows or whatever the speech therapist is recommending for this specific patient. And then following up with that of, are there exercises that can strengthen the tongue muscles, strengthen the voice muscles, and maybe modify the diet as this disease progresses so we're less likely to get one of those aspiration pneumonias. Other big thing too, right? Cognitive training. So there's been some evidence that these cognitive training programs, especially earlier on, to help try and prevent it or like learn it when we still have as much good cognition as we can during these diseases, we see better cognition, attention, processing speed, visual spatial functions, and memory. Again, some of our other diseases like PSP, MSA might have a lot more dysphagia, dysarthria, so they might be thinking about how do we use a communication device with this known progression, knowing that it's going to be coming eventually, as well as external aids, right? Cognitively, again, these patients do well to some of those external cues as opposed to those internal stimuli, which they're just not getting quite as well as they used to. All right, and then again, additional resources for you guys from the PowerPoints later for Parkinson's specifically. And then we're going to switch gears a little bit and go to Huntington's disease. Uh, So Huntington's disease, also a movement disorder. So this one is purely genetic. So this is a gene from chromosome 4, where if you have this expansion of the CAG repeats within that gene, you start getting this protein produced, which is abnormal. And then that abnormal protein is very toxic to brain cells in particular, a lot of other cells as well. But because the brain cells don't reproduce, aren't replaced on a regular basis, like, skin cells or blood cells, we see a lot more of that brain effect as compared to the rest of the systemic effects with this disorder. So it has a triad of symptoms. So we have motor problems. So you both have abnormal involuntary movements, as well as a reduction in your control over your voluntary movements. Psychiatrically, this can have a wide range of problems from depression, very impulsive behaviors, apathy, or kind of the lack of motivation to do things, irritability. They can also be very obsessive about things, kind of their brains on repeat, which can be very problematic for certain patients. High risk of suicide within these patients as well because of kind of everything that's going on here. And then cognitively as well, right? So we have reduction in speed of processing, their flexibility of thinking. They're a bit more concrete with their thinking. And they have a lot more frontal lobe dysfunction. And that's where we do a lot of our planning, prioritizing, kind of our executive functioning skills. And so this typically starts in kind of prime years where you should be productive, having families and doing things in your career. So depends on the number of repeats within this gene as to when this starts. So the fewer abnormal repeats you have, the longer you're able to live a healthy, normal life before you start noticing those symptoms. Whereas the longer that repeat expansion is, the more abnormal that protein is, so that toxicity becomes apparent much earlier. So usually age of onset's between 30 to 50, but again, you can have juvenile onset where we have, again, kids in elementary school presenting with movement symptoms, cognitive symptoms, etc. So typically we're going to be making this based on the motor onset and presentation. So that would be physical exam. We're seeing chorea, which are quick, involuntary, kind of dance-like movements. So rather than the tremor, which is regular and repeated and rhythmic, the chorea is kind of flighty, moving from one part to another, not necessarily predictable as where it's going to go next. And then we confirm the diagnosis both by taking a family history to see is this kind of an autosomal dominant pattern, but this also might be just the first person who's presenting to us to get the testing. So then we do the confirmatory blood test to see how many repeats of this gene do they have. Again, you can get one copy from one parent, and so all you need is one abnormal copy to have this disease. And so then you have a 50-50 chance of passing on your abnormal copy to any of your kids, or you could pass on the normal one, and then that kid with the normal copy does not end up having the disease. Right now, we still don't have any treatments that are available to slow, stop, or reverse the progression. We do have a lot of clinical trials, so there's some that are looking promising, but nothing that's quite close to market yet. You may have seen a headline about new medication recently through BBC, but again, that one's still in clinical trial phases. It's not close to being approved yet for treatment of Huntington's disease. And then death, again, largely variable depending on kind of this CAG repeat number and the severity of their disease, but it is going to progress over the course of, again, decades from onset here. So again, going over motor symptoms and how that might impact physical therapy, occupational therapy. So again, chorea is going to be that quick, kind of flighty, irregular movements, can affect anywhere, right? So it can be mouth movements, leg movements, arm movement, trunk movements as well, which can throw people off balance or have difficulty with their activities of daily living. Dystonia tends to be rare in like adult onset early HD. We might have more of it if you have a juvenile patient. And then as that disease progresses, we move from less of the abnormal choreas and more into the dystonias, which are more fixed postures and muscle contractions. And it can be very painful if we're having a lot of pulling that we can't really relieve for the patients. And they might also have that Parkinsonism. So we talked about, again, slowness, stiffness with movements that can also be seen in Huntington's disease, but again, with these other movement problems as well. All of these contribute to impaired mobility, feeding, communication. And so our goals in therapy are trying to improve those, reduce, improve safety, and then reduce any complications coming from those. Right, so we want to involve physical occupational therapy early and frequently. So early stages, our goals are trying to delay the onset of problems as best we can, and then maintaining function, right? So these are still people who are trying to work, trying to raise a family. How do we keep them in the situation where they can do those things that they want to? All right, so with the chorea, with the abnormal movements, do we need something that's more weighted with the utensils so they can eat things a little bit easier? Do we need to make sure things are padded, whether the bed rails or the seats or something that's a little bit more comfortable? So if they do have a abnormal quick movement, they're not going to injure themselves in doing so. Um, Again, we don't want to do limb restraints, right? So again, the thoughts of especially in nursing homes, you can have someone who's moving too much that we don't like. It might be a danger to themselves. They're going to try and, strap them down or hold them down as best we can, for their safety. But really, that's not particularly safe or helpful for these patients. Again, looking for skin breakdown because, again, infection can be another significant problem for these patients. Again, positioning of the bed is something that we're looking at as they have large amplitude, especially trunk movements there. When we move into the later stages of Huntington's disease, we're now less focused on, again, preventing problems, but now we've got the problem and how do we limit any complications? These patients are also going to be still high risk for fall injuries from falls, which are going to wind them up in the hospital, right? So as they're losing their independence with ambulation, when are we using a wheelchair, right? That transition from a walker to a wheelchair, not something patients are necessarily wanting to give up on their own. We need some of that reinforcement from therapists of like, nope, this is going to be the safer thing that keeps you, at home rather than in a hospital or a rehab facility because you broke your hip and kind of thinking about it more preventatively in those regards. Same with activities of daily living, right? They're going to have more difficulty feeding themselves, dressing. Do we need any modified equipment for utensils, bedside commode? Is that going to be easier for them to get to, or they can still do some of it independently without needing the diapers and having the kind of skin breakdown, et cetera? So again, we usually do a multidisciplinary clinic for our HD patients where I see the patient and then our physical therapist, speech therapist, occupational therapist will also do an assessment and can give me some guidance of, hey, they would really benefit from a prescription for this thing in particular, and can we get that from the medical supply store for them, et cetera. Other benefits too, besides the preventative and the preventing problems and complications too, would be other ways that it benefits these patients. About 80 to 90% of Huntington's patients will have sleep disorders. That can be insomnia or they're having trouble staying awake, or sorry, difficulty going to sleep. It can be fragmented sleep where they're not sleeping great within the night, where it's very broken up by their movements or other problems. So We recommend as part of their sleep hygiene, developing routines, right? So want you exercising either early in the mornings or even if they're very prone to napping in the afternoon, we tend to have the loss of this normal circadian rhythm. So the Huntington people might end up producing melatonin in the mid-afternoon where we're not supposed to be going to sleep, right? So how do we combat that? Recommending physical activity, exercise, kind of during that peak time when they're trying to fall asleep, and we want them to stay on a more regular 24-hour cycle. Like we said earlier, mood disorders also very common in Huntington's patients, and so physical exercise, trying to get those endorphins moving, can be very beneficial for these patients here as well. All right, and then switching gears here a little bit on the speech and voice changes. So this is also a combination of, again, the motor integration is problematic for them. Cognition is declining progressively, as well as behavioral changes or impulsivity that can be problems. So with their speech, we might see a kind of progressive slurring of speech, having trouble with consonants. As their speech becomes less intelligible, they're having a harder time communicating their needs, and they may even progress into mutism in the late stages. A lot of these patients are again winding up in care homes where their caregivers are not necessarily family members who've been with them for a long time. So if they are not able to express their needs, then they have a hard time getting the care that they need in some of those situations. And then drooling is a very common problem there too. And we can get choking, we can get aspiration. Again, those aspirations lead to a pneumonia where we end up in the hospital and kind of spiraling downwards from there. Very common too is weight loss, not just because of the swallowing problems, but also these movements. You're moving constantly, and so you're burning a lot of calories. So we're trying with our meds to reduce those abnormal movements as best we can, but we also need to work on the speech side and the nutrition side of how do we get you to maintain your calorie intake so we don't have a failure to thrive and then kind of keep wasting away from that. So communication boards, right? So we know we have a progressive communication problem. So how do we start these early when their cognitive impairment is not nearly as bad as it will be? We know later in the course, get them trained on it. And they might have eye movement problems. So some of the eye gaze technology might be more beneficial earlier versus later in the disease course as well. Again, because we know we've got cognitive problems that are going to be coming up, don't let it be too complicated. We want simple communication that they can use kind of throughout the course of the disease here, as well as teaching caregivers, right? So explaining to family, to nurses, or other people that are involved in their care, like there's going to be some difficulty. Again, how do we teach you on these communication devices to kind of, again, learn what they're saying, hear what they're saying, be aware of some of these upcoming difficulties we might be processing through. And then dysphagia, right? So if we're having trouble with liquids, that might be straws, thickeners. We might need repeated swallow evaluations to see how well we're doing in that regard. And then changing textures of foods and solids can be helpful, right? So are we doing more purees or smoothies or other things that are a little bit easier for us to get down? As well as can we mix in then higher proteins, right? Can we put a protein powder or peanut butter or something that's in that puree that helps maintain our weight and our calorie intake? Chin tucking and trying to reinforce these behavioral aspects to swallowing early is going to be particularly important. Again, like I mentioned, they might be impulsive, and so they might be eating a little too fast. And so it's going to take repeated teaching and working with them of like, okay, we need to not talk while we're eating. We need to not do other tasks. We need to focus on the one thing that we're doing here in particular. Fatigue during meals can also be a problem, right? So do we need to space things out or make it easier to chew? Or how do we combat some of that fatigue with some of these speech therapy strategies for them? Again, other comments on the weight loss, right? We want them to have access to food when they're hungry and able to eat if we're losing weight. Increasing things like salt, butter, sugar, totally fine, right? We're less concerned about diabetes being a major factor for these patients when we know we've only got a couple of years here where the diabetes is not going to be the problem. It's more that weight loss, which is going to be more of our issue. Again, HDSA has a lot of great resources, a couple other handouts here that I linked to give you guys access to. And then we'll switch gears a little bit to ataxia. So what is cerebellar ataxia? There's also a sensory ataxia. We're not going to focus on that part right now. That could be a lecture all on its own. But cerebellar ataxia is going to be due to an injury or degeneration of the cerebellum, which is going to be this kind of more small part, feathery looking part in the back of the brain, kind of close to that brain stem and the spinal cord here. So this balance center coordinates movement. It's not necessarily your strength, that's another pathway within the brain, but involves kind of the sensory feedback of I'm trying to do a movement. How do I correct that movement in real time to get to the target that I'm trying to coordinate? So if you have a problem with the cerebellum, we see that in the eyes, we see that in the mouth, and we see that in all of the limbs as well as the trunk. And so that we'll get through kind of some of the implications of that here as we talk a bit more about the ataxia. And so the course of a cerebellar ataxia largely is going to depend on the cause, right? So you might have a stroke, a blood clot, or a hemorrhage affecting that area of the brain. That's going to be a very abrupt onset, and then we might have some persistence of that, but we might have some recovery. Usually that recovery is going to be the best within the first year after the stroke. You can get a little bit more recovery long term after that, and oftentimes our patients with like their cerebellar injuries tend to have better recovery than the patients who have a lot of aphasia afterwards or weakness afterwards. But again, stroke is going to be sudden onset and then some delayed recovery. An inflammatory process or an infectious cause attacking the cerebellum, typically not going to be a instantaneous, but kind of a over days or over a week, we suddenly have some gradual onset. If you're able to identify the infection, treat it, and get that resolved, then again, you have a good chance of some recovery with the rehab from physical therapy, speech therapy, occupational therapy, but might be depending on, again, if we can get that other underlying cause under control or not. Our, again, more progressive and harder to treat ones are going to be our paraneoplastic or prion diseases. So paraneoplastic, we frequently will see this with like a ovarian cancer, uterine cancer, kind of a gynecologic cancer, and produce antibodies, where those antibodies are trying to attack a cancer, and that's part of how our immune system reduces cancer. But this antibody is mistargeted, so it's now starting to attack a different part of the body incorrectly. So there are certain cells within the cerebellum which can look very similar to these other proteins that they're trying to attack. And we get cerebellar degeneration in the setting of those cancers. So that would be a paraneoplastic process. And then prion disease is something like Creutzfeldt-Jakob disease or mad cow disease. If we get an abnormally folded protein, these can be, again, variable in their progression, where it's definitely going to be kind of more on the weeks to months side of things rather than like an instantaneous onset. Very hard to treat both of them. Both of them tend to have pretty poor outcomes in regards to recovery. And then there's a large category of neurodegenerative, which is mostly what I see and focus on. And so these are going to be chronic, so over months, years sort of progression. And so, number of different causes. So, this can be genetic reasons. So, there's a whole class of disorders called spinocerebellar ataxias. So, a number of genetic mutations can be autosomal dominant, where again, 50-50 chance that you get one from a parent, or there's some like Friedreich's ataxia, which is an autosomal recessive. And this one is you need two copies, so like one from each parent, or one from a parent, and then your other copy from the uh, second parent had a mutation in it for some reason. And so you need two abnormal copies for something like Friedreich's ataxia. And those ones, again, depending on the type of the genetic cause, might be starting in childhood or they might be starting later in life, depending on what's going wrong with it. Um, then diseases we talked about a little bit earlier, MSA or PSP, both of those can also have a cerebellar subtype. So rather than looking clearly Parkinsonian, they might have more of an ataxia pattern to their movement problems here too. Both of those, again, due to an abnormal protein that's building up over time and going to be progressive over the course of a couple years.
We have a
So,
question, Dr. Sipma.
yes. Uh-huh.
Ellery Ashcraft asked, is Huntington's disease often diagnosed early through genetic testing, or is it primarily diagnosed when symptoms start to appear?
So, with genetic testing, as long as the patient is over 18 and able to kind of identify reasons why they want to be tested, we can do predictive testing before motor onset. But there's a lot of genetic counseling that we do kind of before they're making that decision, with known genetic mutation that can affect your ability to get things like life insurance, long-term care insurance. There's a number of protections under GINA for, again, you can't lose your medical insurance, but there's other elective things which can be impacted if you know you have a hereditary disorder like that. Um, and then there's also the components of how are you going to use this information? Is this going to, again, just be, I'm worried about it, that's all I can focus on, downward spiral? Are you in a good headspace for that? Or are we learning because we want to be proactive and preventative, kind of choosing a job that's going to be able to do a little bit more long term? Family planning, too, we might consider doing early preventative or like a predictive testing, because there is a way now to doing IVF. You can screen the embryos to look for the ones that don't have the HD mutation and implant those embryos rather than all of the ones. So there's some reason someone might consider doing it, but it's up to the patient to choose to do that predictive testing. After motor onset, then this is more confirmatory of, again, clinically, we think you have this disease, but we want to be kind of confirming, knowing your repeat number can give us some guidance as to how we can counsel you as how fast this might be progressive for you. And again, letting your family know about this as well. Kind of, they have a 50-50 chance if you're a again, son or daughter of a parent with HD. So, kind of complex reasons that you would want to go through genetic counseling before you make the decision if you're not symptomatic. And then with symptoms, again, can be helpful for predictive as well as research. So, again, I mentioned we're doing a lot of research studies. So, we're trying to catch things earlier where we can slow progression before we're at a late stage, right? We want to slow it when we're minimally symptomatic or pre-symptomatic, not when we're already in a nursing home and dependent on somebody. So a lot of the shift is how do we identify treatments that are going to be working kind of very early in that process. So those are some of the considerations there. Very patient dependent, family dependent, and we're going to go through a lot of talking with the patient before we jump to doing a genetic test like that. All right, great. Okay, so back to cerebellar ataxia. So again, kind of big things we're going to look at. So gait pattern is what I'm looking at in particular. So up top here is like a normal pattern, right? You have one foot after the other. You have regular spacing between each step. You have each foot is kind of within a certain line. With an ataxia patient, they have a lot of trouble coordinating, right? So we have shorter steps. We have irregular placement of those steps, right? So they're kind of all over the place there. So that's more of an ataxic pattern with their gait. They tend to be more wide based, right? So again, shoulders should be about over each of these feet. So some of these ones you have pretty wide distance between each foot placement there, which is typical of an ataxia. And then again, these movements, abnormal coordination, you might look like a tremor, so kind of an all over the place movement of the limb or the trunk. We're having trouble hitting the target that we want to. And then this can range from mild to severe trouble hitting the target with their hands, their eyes, their feet. So again, with gaze too, you can have trouble with the eyes focusing where we want them to. They might try to move to a target, but overshoot and then have to correct back, which can be a little disorienting for patients as well. And then depending on the disorder, yeah, you also might have other movement disorders or other neurologic problems going on with it. So some patients have Parkinsonism, so SCA3 tends to have a lot of the slowness, stiffness. You might also have some dystonia or spasticity, which is causing muscle pain and stiffness. Neuropathy, so loss of sensation in the feet, is common with Friedrich's, and can also further impact their ability to function if they're not feeling things quite as well. A lot of physical therapy is going to be focused on how do we prevent falls and maintain function, right? So maintaining core strength, balance as best we can. So there's a number of different static and dynamic balance and coordination exercises which can be helpful for patients, as well as thinking about, okay, if we are falling, how do we then get up safely from falling or fall without injuring ourselves quite as drastically? to our other things too, is like what assistive devices are going to be useful for this patient in particular. Do they need any home modifications, knowing that this might be a progressive neurodegenerative disorder? Or is this again something like a stroke where we're going to rehab and use this thing while we need it and then eventually get rid of the walker or assistive devices there? Occupational therapy, again, typically we've got patients who are in the prime of taking care of jobs and families and doing other things. So, are there things at work or at home that are going to be more useful for them? Weighted tools, pens, there's tremor pens or ataxia pens, which rather than one straight pen, it's more like a Y shape. So, it gets you to hold things in a slightly different way. And again, retraining the brain how to use that. So, it's using different pathways can be helpful. Dressing devices can be useful, that like Velcro, or things that will hook buttons that are a little bit easier for them to hold a thicker handle as opposed to the small button that they have trouble targeting. Right, preventing disability can be also a focus with occupational therapy. How do we develop daily routines, a home exercise program that's going to keep them doing the things we need to? And then maintaining overall health too, and energy conservation. Again, doing movement is just taking a lot more work and focus than it used to. And so, how do we minimize the fatigue so that way they're able to function on a um, optimized brain as best we can? And so those muscles aren't getting weaker and then more and more difficult to control. Speech and swallowing changes come from that trouble coordinating the movements of both the airway as well as the tongue, the lips, all of those muscles involved in swallowing. So they may frequently have an airway which is still unprotected when they're trying to swallow things. And they also have more trouble integrating that sensory feedback, right? So your nerves are still intact, but the cerebellum, which processes how does that positioning sense tell me what I'm doing right or wrong, is impaired. And so they don't have that immediate correction like we would in a normal functioning cerebellum. So they tend to have poor articulation. They have trouble with consonants, poor prosody. Their speech might be scanning, where we have breaks within the word or the sentence, which are at an abnormal pattern than we otherwise would hear. Voice quality can sound very different. Depends again too if we're more spastic, if we're more hypophonic, if there's other movement disorders kind of contributing to those voice muscles in particular. Resonance to breathing patterns, those are going to be very different with irregularity and ataxia compared to some of our other disorders. Then again, I mentioned because that airway is less protected, we might have more risk of aspiration, which can wind us up in trouble in the hospital. So some of the things that have been studied with ataxias, so similar to the LSVT treatments that we use for Parkinsonism, can also improve voice quality in ataxias for patients. Breath control techniques can help with managing their pitch, their loudness, and can improve some of the voice quality for them. There's a Melbourne Ataxia speech treatment. So this is a home computer training program. So they record them speaking, and there's audio feedback to kind of how they're talking. Right now, it's only in Australia, so it is tuned to the Australian accent, and so it wouldn't be particularly useful for American or Britain or someone like that. But that's kind of in development, and so potentially translatable to other places eventually. And then, like we talked about before, alternative and augmentative communication devices. Is this a neurodegenerative one where we're needing something long term, or a short term sort of thing where we need some other way to communicate because our voice is just a little too ataxic or spastic right now? And then swallowing evaluations, right? It's similar to what we talked about before. What tongue movement, exercise, mouth movements, or voice therapies can we do to help with preventing some of that aspiration? Do we need to think about posture, or adjusting any of the textures to what we're eating to get it better down into the esophagus where it belongs? The National Ataxia Foundation, one that I would highly recommend. The lsvtglobal.com too. So if you have a patient who's looking for someone trained in LSVT, either big or loud therapy, you can search by zip code on that website, which can be helpful for identifying a good place for your patients. The ataxia.org.uk is the UK-based one, which also I think has some good resources there for people looking at it. Now we're running close on time, so I'll just hit a couple highlights here on other movement disorders where we use some of these other therapists. So tics and Tourette's. These are involuntary movements or vocalizations which start in childhood. They may resolve over time or they may persist into adulthood. And so, comprehensive behavioral intervention for tics, or CBIT, is run by occupational therapists at UAB and at Children's. And so, this is focused on psychoeducation, social support, tic analysis, relaxation, kind of self-awareness, and combining all of those things to reduce those abnormal movements that were or vocalizations that we're having there. Dystonia, we'll talk about more in one of my other talks here, but it's again abnormal posturing or pulling of muscles, maybe fixed or tremulous. Most common one that we see is going to be neck movements with it's just a dystonia. Again, it might be with Parkinson's or cortical basal or just Huntington's disease, and then we have more limbs like an arm or a leg movement. But I will frequently refer to physical or occupational therapy to help with the retraining of the brain and body connection. We'll get into a little bit more in another talk as to how dystonia comes about. But again, it's a processing issue of we don't feel where things are at quite correctly. And then we have abnormal signals coming from the brain to try and move things. So we're trying to retrain those abnormal inputs and abnormal outputs to get them to move correctly again. This can also have a lot of reduction in range of motion and might have some pain. So the therapy kind of goals there would be how do we kind of restore some of that normal function, normal range of motion, and reduce some of the pains and from those postures that they're having long term. And then functional movement disorders, again, a whole nother category we could spend a whole nother lecture on. These are involuntary abnormal movements that aren't caused by structural damage, right? So there's no stroke, there's no multiple sclerosis, there's no brain physical damage that is ongoing, but we've had kind of an abnormal hyperactivation of our fight or flight response or our dissociation response, typically in response to traumas or stressors or physical things that are going on or emotional things that are going on, which then present with abnormal movements. So, trying to treat these ones, we don't have a medication that works particularly well for this. It is really a cognitive therapy to, again, address the brain sending these abnormal signals, as well as the physical occupational therapy or speech therapy, depending on which movements are going on, to help retrain kind of from the physical side to the brain. So, kind of working from both ways of providing more stimulus from external, as well as cognitively trying to retrain brain patterns so that way we don't have those abnormal movements like we normally are in this disorder. So, so yeah, that's brief overviews. Hopefully some good learning points for you guys on all of these disorders as to, again, lots of prevention, a lot of being proactive and trying to implement these things earlier rather than we've now had a fall, we've now developed dementia, now we cannot communicate. We're trying to be aware that these problems are coming for these patients and how do we instill good behaviors or learning or adaptive things to help them prevent some of these complications and problems in the long term.
Wow, that was really enlightening and a lot of information. Thank you so much. And I look forward to seeing you in a few weeks when you join us again. And at that time, I think you speak on dystonia. Is that correct?
Yes, that's
Forward to
correct.
that. So
Yeah.
if you're here, if you're new to us, you must do our evaluation to receive a certificate. The evaluation link, I'll read one more time, https colon / www.surveymonkey.com / lowercase r / all uppercase letters V as in victory, Z as in zoo, B as in ball, V as in victory, QQ5. I'm pasting that again. The password is movement with a capital MOVEMENT. So I'm seeing the link is not working. Let me see why that is. All right.
And I'm going to have to hop off for another meeting,
Thank you
but
so
thank
much,
you again
Dr.
for
Sipple.
having me. I look forward to seeing you guys in a couple weeks.
Yes. All right. Thank you. I'm posting the link again to see if it works. Try this. It may have been that you copied it or it had a period involved, which messed it up. But is anyone trying the new link I've just posted? I can get the slides. Yes, Miss Desmond. I'll ask Dr. Sipma for the slides. I think the link must be working. I thank y'all for being here. We'll be back in a couple of weeks with Dr. Jason Newell, who works for the University of Montevallo, and he will be presenting trauma informed supervision. So we look forward to that. If you're a social worker needing a supervision hour, here it comes in 2 weeks. Y'all have a great couple of weeks in between, and let me know. Shoot me an email if you can't get the link to work.